Golden Notes, Psoriatic Arthropathy. If first-degree relatives of patients with psoriasis have joint problems, psoriatic arthritis should be considered. It is a chronic progressive seronegative inflammatory arthritis occurring in patients with underlying psoriasis, most commonly a seronegative oligoarthritis found in patients with psoriasis. Oligoarthritis, most common, accounting for 70% of cases. Autoimmune disease associated with an increased frequency of HLA-B7 and HLA-B27. Epidemiology affects men and women equally. The range of age of onset between 35 to 55 years. Around 10 to 20% of patients with skin lesions develop an arthropathy. Types. 5 subsets of psoriatic arthritis have been described based on the pattern of joint involvement, with an increased prevalence of the spondylitic form in males and the rheumatoid form in females. Type 1, asymmetric oligoarthritis. It's the most common, about 43%. Symmetric polyarthritis, 33%. Proximal interphalangeal joint involvement. Type 3, sarcoiditis. Type 4, TIP joint disease associated with nail pitting and onycholysis, separating of nail from nail bed. Type 5, arthritis modulans, severe deformity, fingers or hand, telescoping fingers. It is rare. The relation between skin lesion and psoriatic arthritis. In fact, psoriatic arthropathy correlates poorly with cutaneous psoriasis and often precedes the development of skin lesions. Psoriasis precedes psoriatic arthritis in 60 to 80% of patients, usually by less than 10 years. In 15 to 20% of patients, arthritis appears before the psoriasis. Small plaques should be looked for on the elbows and scalp. Features. Psoriatic arthritis tends to affect the distal interphalangeal joints, DIP, can present with or without associated psoriatic skin lesions or only with nail malformations. If no obvious skin lesions are visible, the clinicians must look for psoriasis in hidden sites such as the scalp, inner gluteal cleft, and umbilicus. Nail involvement includes onycholysis, transverse ridging, and nail pitting. Vertebrae may be asymmetrically affected and there may be involvement of the atlantoaxial joint with erosion of the odontoid and consequent subluxation. In fact, dactylitis with sausage digits is seen in 35% of patients. There are some extra-articular features include ocular involvement may occur in 30% of patients, including conjunctivitis in 20%, acute anterior uveitis in 7%. In patients with uveitis, around 43% have sacroiliitis. Synoveitis affecting flexure tendon sheaths with sparing of the extensor tendon sheath. Investigations: elevated ESR and CRP level, negative rheumatoid factor, low levels of circulating immune complexes in 56% of patients, high serum immunoglobulin A levels in 2/3 of patients, radiography, asymmetric pencil in cup deformity in the distal interphalangeal joints of the fingers. Diagnostic criteria established inflammatory articular disease with at least 3 points from the following features: current psoriasis, 2 point, history of psoriasis. In the absence of current psoriasis, assigned a score of 1. Family history of psoriasis. Also in the absence of current psoriasis and history of psoriasis, assigned a score of 1. Dactylitis, 1 point. Juxta-articular new bone formation, 1 point. RF negative, 1 point. Nail dystrophy, 1 point. Differential diagnosis. The condition can be distinguished from the sarcoileitis seen in ankylosing spondylitis by the presence of the other clinical signs in the nails and the skin, and by differences in the patterns of vertebral involvement. Polyarticular psoriatic arthritis distinguished from rheumatoid arthritis by presence of dactylitis and absence of anti-CCP. Management: treat as rheumatoid arthritis but better prognosis. In limited disease, NSAIDs usually sufficient, but do not prevent progressive joint damage. Patients with progressive peripheral arthritis, polyarthritis, joint erosions, or oligoarthritis refractory to NSAIDs and or intra-articular corticosteroids require disease-modifying anti-rheumatoid disease therapy, for example, methotrexate, early in the disease course. Methotrexate will improve both the joint and skin problems. Sulfasalazine is safe to use in pregnancy, and there is no need to stop it. Sulfasalazine tends to only improve joint symptoms and not improve the psoriasis. TNF alpha inhibitor may be considered as a second-line therapy for most disease manifestation. If not respond to an adequate trial of 2 DMARDs, for example, leflunomide, methotrexate, sulfasalazine, then anti-TNF agents. Apremilast, phosphodiesterase 4 inhibitor, reduce anti-inflammatory cytokines and mediators associated with psoriatic arthritis, including TNF-alpha and interleukin 23. Apremilast, alone or in combination with DMARDs, is recommended for psoriatic arthritis only if they have peripheral arthritis with 3 or more tender joints and 3 or more swollen joints, and not responding to adequate trials of at least 2 standard DMARDs. Adverse effects: gastrointestinal disorders, most commonly diarrhea and nausea, upper respiratory tract infections, headache, and tension headache. Stop apremilast at 16 weeks if the psoriatic arthritis has not shown an adequate response. Hydroxychloroquine for exacerbate psoriatic skin lesions. In patients with cutaneous psoriasis, systemic corticosteroids predispose to pustular psoriasis and may result in a flare of skin psoriasis when they are stopped. This was provided by the SSSM Study Smart series for Mrcp, your easy way to easy pass. Don't forget to follow us on Facebook, Telegram, and YouTube channel. Thank you very much.